All right, welcome everybody. We're going to get started. My name is Chris Miller. I'm the founder and CEO of the Mission Center, and I teach entrepreneurship at UMSL. I'm quickly going to introduce our panel, but just to make sure we're all on the same page. So essentially what this panel is about, although you guys can take it in whatever direction you might want, we're going to explore how AI can help individuals more efficiently obtain, communicate, process, and understand health information services to make appropriate health decisions. So we're really lucky to have with us Dr. Catina O'Leary, CEO of Health Literacy Missouri. I am going to read this even though I know most of it, but I'm still going to read it so I don't miss anything. Dr. O'Leary is the president and CEO of Health Literacy Media, a nonprofit organization that works to make health information more understandable and actionable. Prior to working at HLM, Dr. O'Leary was a faculty member at Washington University with research interests in connecting community members to health resources and services to improve health and the quality of life. Blake Marggraff, CEO of Epharmix. He's the co-founder and CEO of Epharmix, which is an art grants recipient company that automatically keeps the toughest, most expensive 20% of patients in touch with our outpatient care teams at risk-bearing healthcare organizations. Previously, as a full-time student, Blake co-founded BetaBox Labs, a company which has served greater than 30 institutions and more than 10,000 students across the country. And last but not least, Michael Kehoe, founder and CEO of Johego. Johego is a nonprofit tech startup that develops software to help social workers, police officers, nurses, and other public servants more efficiently connect people in need with essential medical and social services. Additionally, he is a licensed professional engineer and an adjunct professor of entrepreneurship at WashU in St. Louis. A couple ground rules. So we do not think that interruptions are rude. We think they're a sign of passion. We very much want you guys to be involved in the conversation the whole way around. And so it's not just like a Q&A at the end. So raise your hand, jump in at any point, and we're going to get started. I'm going to ask a question for Catina just to get it running. And anything you guys want to pipe in, please do. So Catina, based on your work at HLM, will you talk about the importance of connecting health information to health knowledge from a patient and provider perspective?
I feel like I should have seen this before and been prepared.
Oh, I'm sorry. That's Michael's fault.
No, so at Health Literacy Media, we spend a lot of time thinking about how people get information and how they process it and how they use it. And the fact of the matter is, some of us are really good at reading and writing and understanding information. We're overeducated. We spend a lot of time thinking about it. And the fact is, when we get sick, all bets are off. Right? That's the story of health literacy. When you're sick, everything you know doesn't matter anymore because you're in a novel situation, you're really scared, and all the things that used to apply don't really apply. You don't think as fast, you don't have the information to connect to other things, you don't process the way you want to, and you don't even know where to start. So there's a great New York Times series about 5 years ago where they talked with doctors and they wrote a lot of op-eds about their experience getting cancer diagnoses and having heart failure and things like that. And you know, they would all talk about when they got their own diagnosis, they would go back to their smartest colleague from medical school and call that person and ask who they should talk to in that situation. So even with all of their advanced education, they couldn't make sense of their own situation or their partners. So it wasn't just their own health. If it happened to their wife or their child or their partner in any other way, they would really struggle to figure out how to do it, and they would go back to these expert folks because their own knowledge didn't apply. So we're creating systems here. That's what we're talking about, is creating systems to help people make decisions, but I don't hear a lot of conversation about how to help people understand when the social environment fluctuates. I think that's an important conversation, and the fluctuation comes when you're sick, when things change, when your kids are sick, and that's what we should be talking about.
Mm-hmm. Any comments, questions from either the panelists or anybody in the audience?
One anecdote that you taught me about the importance of health literacy. So how many here in the room have ever been given a medical prescription for something that you're supposed to take once a day? Right? Well, in Spanish, ONCE is once, which means 11. So if you don't speak much English and instead are primarily a native Spanish speaker, there has been a non-trivial number of cases where people were taking their medication 11 times the recommended dosage. And so if your artificial intelligence algorithm that you are creating, this chatbot, et cetera, is just churning out the same information faster, that it's bad information insofar as it can't be understood by its intended audience, then you might be just perpetuating harm and not even realize it.
And so since you brought that up, I'll go ahead and give some other examples. So another example is when it says 2 or 3 times a day, and you don't specify that you mean at morning and night, 8 a.m. and 8 p.m., A lot of people don't know what that means, and so there are tremendous examples of people taking their medicine when they wake up, and then again a half hour later when they eat their breakfast. So getting both doses in a 30-minute or hour period. That's not the way the medicine's supposed to work. That specificity is really important, and you can't understand it unless you talk to people and you actually think about how they're using it and how they're processing the information as it's written.
Mm-hmm. Any other questions or comments from the audience? All right. Michael, based on your work at Johego, will you talk about some of the difficulties associated from aggregating and validating health information?
Sure. So there's a Silicon Valley nonprofit technology company led by a MacArthur genius called Benetech, and they estimate that it costs as much as $140 to collect and verify information about just one service provider. So things like hours of operation, financial requirements, documentation requirements, et cetera. And the reason why it's so expensive is that the only way that you can reliably get information about that service is by calling and asking them. Many nonprofits don't have the financial bandwidth to readily update their websites. Their websites are often in different formats. And moreover, standardization of information is also a challenge. So one person's overnight shelter might be another person's emergency shelter, might be someone else's transitional housing. And all of these words have different meaning, different people. And so you have to be very careful about when you're asking what services somebody provides, that you're actually sort of getting to the ground truth. So I guess I'll probably skip what Johego does sort of in this space to sort of streamline that process. But the result is that social workers, nurses have to rely on this sort of patchwork of ad hoc solutions to try and get information that's relevant to their clients. So they talk to their colleagues, number one, which ties up two people. They do hours upon hours of Googling, which is inefficient and not reliable. Or they have literal printed paper directories where they scratch things out with their hands and overwrite it. And the result is that you spend more time chasing information than helping clients. That leads to burnout of the practitioners. Not to mention, often those in need fail to get the care they need when and where they need it. So there's a lot of room for improvement in this sector.
Mm-hmm. So at some point, we definitely do actually want you to talk about how Johego deals with that issue, because that's kind of the point. Okay. So why not now? Okay, all right.
So basically what Johego does is we aggregate various online government databases. So the Housing and Urban Development, IRS, Missouri Attorney General, et cetera. And once we aggregate those, whenever we observe a data gap or discrepancy, we address that through a distributed network of remote freelancers via the Amazon Mechanical Turk platform. It's so-called human-in-the-loop data processing. One of the fun things about that is that in full compliance with one-party telecommunication audio recording consent laws, we're able to record those conversations. And so it's the same question being asked over and over again with the same few categorical answers. And that corpus of data can be transcribed in a text and be used to train an AI to make those calls for them. And I think that's probably one of the reasons why I'm here today. So instead of having this remote freelancer, this group make those calls at a much reduced cost than traditional methods, you can actually have a machine do it for you and get most of the information you need.
Mm-hmm. Any questions for Michael before we move on to Blake?
Yep. No, it was interesting. So you're talking about maybe a chatbot or something like that, or what's the mechanism by which you're administering the survey? Is it sort of automated system like Eliza or something like that that's calling?
So,
and in the second part of that is, and how do you verify the what's the validation of the individual, and is there any PHI or HIPAA data that's transferred during that call?
Sure. So a few pieces to that.
Clarify acronyms first.
Sure. So the reason why we started thinking about recording, transcribing, and analyzing phone calls in the first place was because our remote freelancers were trying to take advantage of us and said that they were calling providers, and when in fact they weren't. So what we did initially, we had like one person call the provider each week, like one time each week, and so the first two say they're a mental health provider. Then the third person says food bank and job training center. So that one's probably not believable. But probably not believable is not good enough when you're connecting people in need with like social medical services. So we had to institute a variety of mechanisms for ascertaining whether a call was actually made rather than somebody going to a website, whether the call adhered to the script that we had provided to our workers, and whether the information entered in the form corresponded to that which was repeated to them. And so we developed some pseudo-automated processes for analyzing that data. but that analysis isn't yet fully automated. And so right now, we're still building, we don't have a sufficiently large data set to train a full Duplex AI to make those phone calls for us. We've added maybe like 3,300 providers to our database in this fashion, but we're working on a couple of proposals now that if we were to close, then we would have, like several states worth of phone calls. And at that point, you can really start training an AI to make those phone calls. So we're not there yet for a fully automated fashion, but that's something that we're in the process of building. So does that, oh, and PII. So personally identifiable information, that's kind of a recurring theme. We have tried to train our callers not to request personally identifiable information about any of the organizations. But the good news is the information they're collecting is all publicly available information. So hours of operation, what services do you offer, pricing information, et cetera. Like all these organizations have a vested interest in sharing that information with the world. So for the most part, they've been pretty eager to share it. So does that answer your question? Okay, maybe we talk afterwards. Does that sound good? Talk afterwards about it, offline? Yeah. Okay.
Anybody else? Yes, ma'am.
I have two things. I'm a dentist, and I had a kid pass out. Their mom was an EMT and was freaking out, didn't know what to do. Like, as I was in the back, and they had to come get me, the kid didn't even have, like, it was terrible. Like, she just totally had no idea what to do because she just changed. And then the second thing, years and years ago, I was diagnosed with a kidney disease, and I was misdiagnosed, and I was 25 weeks pregnant, and I'm lucky I didn't lose my child. They don't even know how I didn't lose my child, but if I had had information available to me, it actually was an easy diagnosis, so it was like, it was a new doctor, blah, blah, and whatever. But the need is just, I'm just kind of reiterating that.
And I think the point is that these services they're activated during crisis, right? So the circumstances, one, it's real, right? It's really, really important. And two, we don't act as logically as we might otherwise. Blake, last but not least. So what are the potential risks and rewards of AI-augmented health communication?
And I think that's the crux of it in healthcare. We are asking what's generally opaque, if not a complete black box, something we don't fully understand. We as the technologists are asking the healthcare professionals to trust that this will help augment their care. And I'd put this into a simple 2x2 grid when we talk about artificial intelligence to augment healthcare. On one side is, does it touch patients or not? And the other is, does it have clinical implications or not? And for the things that don't touch patients and don't have clinical implications, like more efficient billing, AI is already there. Whenever you went to your doctor, especially if that conversation was recorded, but even if the doctor just took handwritten notes, guarantee that went through some kind of NLP and your health system squeezed as much money out of that conversation as possible using AI. But for things that do touch the patient and are clinical, that's really where the question comes up. Let me share an example of two solutions that my company Epharmix has developed on the predictive side and why they seem similar but are totally different. Epharmix helps keep really medically underserved patients in touch with their providers. It's a lot of fun, helps a lot of people. We do it with text message. We ask questions to patients, and turns out if you ask the right question, you can help a lot of stuff not go bad, people not die. Once you have data, and once you also have the end result for a patient, then you have what you call features, and then what you call the ground truth, right? Which is pretty much what you need to do some supervised machine learning. That's kind of the crux of this whole conference. We have data for patients with depression. We also have data for patients with diabetes. We also have the ground truth. We know if the patients with depression, in this case, attempted to commit suicide. We know if the patients with diabetes had a higher or lower A1C, the toxic chemical in the blood of people with diabetes. We trained two models. Both of those models were able to predict with pretty high area under curve whether the patients with depression and the patients with diabetes, respectively, would attempt to commit suicide or would have a higher A1C. The feedback for both was, that's awesome, but only the A1C model has a remote chance of being used by most of our partners. because the implications for knowing that something could go wrong are so high that although I would argue it is almost indefensibly a fantastic benefit to know that someone is likely to attempt to commit suicide, that's too much risk right now for the system. It doesn't fit with the standard of care anywhere. So, long answer to a really short question, but that's the crux of it right there.
You know, I also want to comment about that, though. We had a conversation, we've been talking a lot about how these models predict, and I think that's really important, but the difference between suicide and diabetes is really critical here as well. So if you have diabetes and you have been educated about what to do to keep your A1C in check, you've got a program for that. You monitor the way that you exercise, you monitor the food that goes in, you take your insulin, you do all of these things, and it's a pretty stepwise approach, right? The likelihood that something goes haywire, if you've not done anything different, is pretty low. If you're depressed and you're at risk for suicide, it is not a linear approach, right? We actually have to like play it out and let humans experience their life. All these other forces come into play. Somebody can actually be doing really well on all their medicines. They can be behaviorally supporting themselves, and their grandmother dies. Or their ex-boyfriend from 14 years ago bumps into them. Or, you know, their depression or their diabetes acts up and makes their depression have an effect. And all of a sudden, their suicidal behaviors are different. And it wasn't predictable at all, except for the fact that you knew that before, maybe that it had happened, but you can't predict all of these other occurrences. Shoo, this is the human part that I think we keep trying to leave out, right? There's all this stuff that you know, and then there's all this stuff that you don't know, and it stresses me out a little bit. So I'm a social worker, right? I don't understand this piece of trying to sort of overpredict what humans are going to do in the healthcare setting where the risk is so high often. And I love everything about what Blake says he's doing, but I think the example of depression and diabetes is really important, and I think we have to think seriously about how we let people sort of play out those experiences and what that means. And part of that is bringing people into the conversations who are experiencing those and not just using their data alone. And not that you do.
We have a question.
Oh, yeah.
So is it the liability issue that is causing that suicide model to not get adopted? Is it the liability, or is it, what exactly is the deterrent there?
I think it's both. So I think from a systems perspective, which is where health literacy comes into play, right? So health literacy happens on a personal system. We all have health literacy challenges. Providers have health literacy challenges, and systems do. So from a systems perspective, the liability is absolutely an issue. But from an ethical perspective and a personal perspective, I think a lot of providers would think about it differently. And they wouldn't just think about the liability that something would happen and you'd be wrong, but the fact that humans aren't predictable in the same way, because the factors that go into predicting depression are really different than those that go into predicting diabetes based on behaviors and lifestyle.
But if this could be like a real-time assistant, it potentially could save them.
Yeah, I don't think it's wrong.
Okay.
So I absolutely don't think that it's wrong to have systems that have some prediction. My issue is that I don't think that we're talking enough about the factors that go in other than just data points that already exist, right? I think that the behavior of depression, in this case, suicidal behavior, suicidal tendency, is really different than diabetes. And it is worrisome to me when we just talk about sort of external data points that we have and we leave out sort of the social determinants of who we are and how we function. So not to say we shouldn't do the work, and not to say anything about Blake's work, because Blake's work's phenomenal. But the example happened to bring up those points that make me think about who we are as humans and how our health functions differently in different scenarios. And I might have not explained that well, so I apologize to Blake if I didn't.
Yeah, hi. We talked about one problem, and that is how people get numb when they're involved in healthcare issues, certainly for their loved ones, and that's real. Let's take that one and put it over here. But I'd like to talk about, and I think it's ironic that we're on the campus of the medical school, and and one of the greatest hospitals in the country. But another one that I see very, very often that I ask the technologists in the audience and also, you know, if there will ever or if there can be an AI solution for the following. And that is that when people enter this institution or an emergency room or anything, I think the difference between competent care and excellent care is usually advocacy, the person who's with the patient, who can speak on behalf of the patient. Obviously, you talk about the uninsured and the underinsured, that frequency of having a capable advocate becomes not as dependable, not as reliable. It would seem to me, if I can close my eyes, because that's what I do for a living, I just close my eyes and imagine things, I don't have to build them. And 5 years from now, there was some type of software that's in your phone and, you know, it knows who you are. And then when you go to a hospital situation, there's a technology that can serve as a patient advocate for the patient who doesn't have the wherewithal to stay evenly balanced, to know the questions to ask, to know where to push, to know the answer is not to accept. Like, that's not good enough. And if something like that is in the future of AI, because I think that is one that will lift all boats in terms of better health care. And it captures literacy, it captures so many things you guys are talking about, but just smart advocacy.
So when you say that to me, I think cool first, really cool.
That's my job.
And then I think, I'm a social worker in my
Okay.
core, right? So then I start to think about populations who have been mistreated in the medical settings historically. And what would it be like for those populations and people in those groups who are terrified of what will happen to them and how the data will be used for good reason, right? So I'm trying to think about what adoption looks like and what comfort levels are for people, and I'm not sure. So there are some populations as a group who have really valid concerns that are based on history, and there are a lot more than we think about. So everybody thinks about sort of Tuskegee and those big issues, but then, you know, if you think about people who have, back to the mental health issues, right? Once your phone app knows about all your suicidal ideations and all those things, what else does it connect to and what does that mean for you? So in the case of your diabetes again or your heart problem, maybe it's okay, but maybe for some of these other things, it's not okay. But then there are also data that say that people are much more comfortable reporting things like suicidal ideation and drug abuse to a computer. So how do we put all that together without talking to a whole bunch of people and figuring out what's palatable? I think that's one of the solutions here. And again, just because we can build it, there's no question that it's buildable, but how do you build it in such a way that it feels good to people and it's acceptable and it actually works toward their better care? And I think that's what we're all going for.
Hello. So I'm a physician here at WashU, and kind of talking to you a little bit and then asking you guys a question. One huge issue is fragmentation of care. So you can have, no matter if they're wealthy or poor, people who come in and have, as a physician, you want to get the whole picture of the patient. Everything matters, you know, their social status, that changes what medications we give them. There are some things that don't change based on those parameters, but there's some things that do, and all the time, every single day, people from every different, social status come in and there's something missing. There's a piece of the puzzle missing, and it's because WashU now has Epic. Well, they came from a system that doesn't have Epic. It doesn't speak to Epic. And so we have to order another MRI, get it done here, have it read by our radiologists so that we can verify what, this person is saying, or we can see for ourselves. And if they have low back pain, okay, then we have to see it for ourselves. We don't trust the MRI. Well, that's another $1,000, $2,000, $3,000 for that patient. And that doesn't even speak to working with social services, working with police departments, working with, there's so much fragmentation that and there are enough data points, but they don't speak to each other. And so that they don't formulate a picture that you can, there's no actionable, there's no actionable, I don't know what the right word is, but there's no actionable, I don't know, I've kind of lost what I was going to say, but consensus. There's nothing we can do based on an incomplete picture. And so I think that there are enough data points. It's just bringing the data points together and making them speak to something that we can do about it.
Thoughts, comments?
Isn't that something that can be solved by an act of Congress? No, I mean, like, mandate it, right? Like, why not mandate every EMR connection, like every EMR system be able to talk to each other through some standard that some NSF foundation, I see a lot of hands going up, so this is a good thing to say.
So there wouldn't be a PBM if it wasn't mandated that drugstores need to communicate with each other.
What's a PBM?
Pharmacy benefits manager.
There wouldn't be an Express Scripts.
That's the problem, that's it.
And that was mandated that these guys must connect electronically so that physicians do know what the drug-to-drug interactions are going to be, and it all could be shared. That was mandated. I'm just bringing that up as an example where the government did step in and mandate that.
Well, we have governing organizations too, like NCPP, that create the standards around those types of things, and we do have interoperability legislated, but yeah, there's huge barriers and difficulties to that, and then there's ownership of the data. So like I work for a company called SureScripts, and that's all we do is prescription routing.
I know you guys are going.
Yeah, so, but we can't do anything with the data. Like we could, apply machine learning algorithms and codify states for medication history data today, but we're not allowed to. So, yeah, that's a real problem.
So, I'm also a physician at WashU. I just wanted to kind of say that I think, so there are some standards actually now for EHRs to be able to talk to each other. I think one real challenge though is that we run into all these walls, and it's really baffling because you see outside of medicine like how much invasion of privacy there is just in other fields, and it's kind of shocking that, and the other thing is that I think that patients want to give this data to providers. Like they don't seem to be, working in oncology at least, I have never had a patient kind of say no to using their data to try to advance the field retrospectively. They want to participate in trials, they want to do this stuff. So, but one thing that I feel like has been missing is everyone's so focused on Epic and the EMR, and it's really just like you mentioned, it's an incomplete picture, right? The Epic does not capture a lot of what happens to these patients when they leave the clinic. We're getting there with symptom monitoring, and I think, one of the companies, I was just Googling, one of you guys does this, but what can we do to sort of connect the healthcare system like Barnes or Mercy to the community, like what these people actually do day to day between the every 3 months that we see them or every 6 months that we see them? That's my question for the panel.
Great question.
Hire the three of us. No, I mean, so one of the things that Epharmix does is they have automated patient follow-up, and that's not just for specialized medical providers, but also, you indicated that you needed a food bank. Did you get to the food bank? Why not? Do you need to connect with another one? Like these are conversation trees that you can set up ahead of time and automate, and that's some of the really cool work that you do. And Johego populates that information. So I mean, we can land people on the moon in a decade, right? Like we can fix our EHR problem. It's like it's a problem of political will, not technology. I would argue.
So one thing that we don't do a good job of is empowering the patient with their data. Yeah. And if the patients had better access to their data, then the bottleneck would be at getting the patient. And so we're trying to benefit the patients. It just seems more natural that we should be driving in that direction rather than forcing a lot of interoperability amongst competing partners that are always going to compete with that. If we force interoperability with our patients, we said, you have to provide this data to the people that own it or created it, then they would be empowered to take that with them. There's initiatives like the Blue Button Project, where they took patient charts and allowed that to be downloaded and shared by a standard and stuff like that. So, I mean, if we keep those standards in mind as we're building things and like trying to push that data out to them, I see that being a driver for those types of large changes.
You know, I think to your point about what patients want, we did a study with a pharmaceutical company about a year and a half ago, and they were focused on their global informed consent for big trials where they were giving people really serious medicines and doing a lot of complicated things to people. And they were interested in figuring out what people wanted and how to make this clear and usable. So we went with their standard informed consent, and we asked people, like, how do you feel about this and what's your experience? And people basically said, this is awful, this is nasty, like these people are trying to take our information and do bad things to us, and we don't trust them, but we don't feel like they had a choice. And then we did a simple rewrite based on all the things that we heard them say. So we heard hundreds of people talk about what would be helpful for them and what they wanted to know. And we showed it back to a bunch of different people. And all of those people had the reaction of, like, it's still long, it's still terrible, you're still asking to do terrible things, but I sort of trust you, and I want good things to happen for me and other people, so I'll let you have my data, even not having any idea what's going to happen to it, because it's the right thing, and you bothered to act like you cared about me and ask. And I think that gets in the way sometimes, is people are so worried that people will say no or that they won't understand it, that they don't bother to ask the question, and they don't bother to really engage, and the result is a bunch of assumptions that are inaccurate. But I think you can get whatever you want from people. I think they will actually do it. They want to do it. They want the world to be better. They don't want to feel mistreated, and they don't want to feel like they don't know what you're doing, or they don't understand, or they're not actually a partner. And that partnership piece is missing pretty much across the board in healthcare, best I can tell.
So I'm a physician, I'm not a technologist, but this stuff is really important and it plays in my mind all the time, and so that's why I'm coming to these things, is to learn about it. And the best option I've formulated in my head, and I'm wondering what you think about this, is to go off what you said, empowering the patient. And so basically having for lack of a better term, a Facebook profile, but it's not Facebook, for every patient that is, the patient can't alter any of it, but they can have an MRI done at Mercy, downloaded or uploaded onto the cloud, and a physician at WashU can get on an internet browser and get on, and there's a username and password for that patient, and they can allow you by just typing it in, and show you the MRI right there. And that, to me, that would just cut down on so many man hours and so much wasted money, where I don't have to tell them, okay, this is our initial visit, that costs you money. I'm going to send you to get an MRI here, that's time and money. And then our radiologists read it, that's time and money. I mean, it just saves so much time and money. And I'm wondering what you guys think about that.
So I'm going to have a couple thoughts. Then, Bruce, Chris, let's do rapid fire, because I'm sure you have a bank of questions.
I do.
So let's do some rapid fire after that,
Okay.
because it's great. This group is passionate about technology, and we've kind of moved a decent amount away from AI, at least in the strict sense. And I think be happy that there are no Epic account managers in the room, because they all be going, shit, I thought we told them we could do all that stuff, all the stuff that everybody has brought up. You have to be able to share from EHRs. In order to qualify for meaningful use, in order for WashU, BJC to pay for the EHR, they had to be able to do that. Patients own their data. If a patient walks up to you and says, I want all my data, you have to give it to them. If a patient says, I want you to email me my data, and you're like, but that's not encrypted, and the patient's like, I want it, you got to do it, right? And if you say, all of this stuff is possible today. My chart, you can share those images today, right? It's more a question of, again, technology adoption and fits and starts, which is why I think healthcare and tech, there needs to be a layer of highly empathetic and experienced consulting in between, or services in between. I'm increasingly convinced, right? You need almost a translator, someone who understands how to implement the tech and speaks the clinical side. Exactly right. But you're spot on. That stuff does exist.
Rapid fire questions. to all you guys, what ethical considerations should be involved when designing, developing, and deploying AI augmented health communications?
I think we've been talking about this forever, but all of these considerations, you know, the core of ethics when you do it wrong is when you don't include people who benefit or experience the consequence, right? If we make things for people, that doesn't ever work. We have to actually engage those people, have them be part of it, have them think with us. That makes our systems work better, and it makes us avoid all of those ethical issues, period, right? Everything else, though, I think I've said my part. Different ones.
Pick a line. Pick a line with regard to morbidity, mortality, probability, and go from there. It's never going to be perfect, but at the end of the day, you know, figure out where the gray zone starts and where you're comfortable.
Earlier today, I heard someone remark about how cost-benefit analysis is essential to any of these considerations, and I would argue that it's actually considerably more complicated than that. If 10 people in the room can benefit from one person suffering greatly, is that still a good thing to do? And so I think having feedback loops built into your system, having folks co-creating, being involved with the design, and just showing a little professional humility in the process, I think can go a long way.
Cool. Can healthcare decisions be made autonomously, and if so, who's accountable?
As an audience member, I don't understand what that means, so they might not either.
Okay. Meaning like could an AI algorithm actually make a diagnosis, right?
Depends, right? So could an algorithm look at my radiology reports and say, this looks like this condition? Yeah, probably. They could probably make some decisions and give some.
Should it?
What's that? Correct. Absolutely, absolutely. Does that happen? Yeah. Can it happen? You know, what we would say in health communications is if that use means that the doctor has better information and can actually spend time talking to people and explaining it and making decisions, that's fantastic. Should it send it to you in the mail or over email without any conversation? We'd say probably not. Right? Like, so what you do with that information is more important, perhaps, than the fact that it can do it. I don't know. Do you guys disagree? Because you were pretty vocal back there.
I just feel like it's like, in certain instances, like reading pathology reports, it's great and it's very strong, but I totally agree with you. Like, it needs to then go through, like, an oncologist. And have an oncologist say, okay, this is how we're going to handle these results. Like,
And weird things happen, right? So I had a biopsy recently. Based on the fact that some algorithm decides a percentage of people that get called back based on certain mammogram results, right? Like 10% of the people get called back. It cost me $1,600 because the algorithm has a percentage of folks they call back, right? So from an ethical perspective, I can afford $1,600. I met my deductible for the year. But is that a problem for some people?
I think some of that also dovetails with privacy, or not privacy, but patient access to data considerations.
Totally.
Because if patients get access to data without interpretation, you run into a whole world of hurt. Someone gets a cancer diagnosis automated on a Friday afternoon, they can't reach their provider until Monday. That, I think, does more harm than like having access to it when they have access to their physician.
So I got the letter in the mail, and it told me to come in right away. And then somebody called me on the phone and said, you hadn't made the appointment yet. So I said, gosh, I'm out of the country. I'll make the appointment on the first day. So I made the appointment on the first day, and I got there. And then that's the person that said, oh, you shouldn't worry too much. We bring back 10% of the people.
Whose threshold, or whose risk threshold are you considering in that too? Because that could be related to profit, or it could be related to patient safety.
Tell me. I don't know. Worked me up.
We have a question.
One quick comment, you guys. Just the American College of Radiology just put out a white paper about ethics, artificial intelligence related to radiology reports and what we should be doing, and it's something that's and then radiation oncology is actually doing the same thing as well, because there's a lot of concerns about everything you guys just talked about, and I think all the physicians view this as like tools to help us do our job. Whereas I think the public is starting to view this as like replacing doctors. So there's all this like fear and everything, but the reality is that all the data issues and everything is definitely needs to be considered, and also the effects of like getting a diagnosis on a Friday when no one can get a hold of anyone. That's.
Other questions, comments from the audience? All right, so what about bias?
We have a question.
Oh,
Right over
sorry.
Regarding, you have a startup, right? And so data collection and all that stuff, as he was talking about, that there'll be convergence of data through different platforms like Your Apple has, you can create Apple ID, you can integrate your health data. They would start giving you, the blood pressure is already monitored, the sugar levels and all that stuff, and this is the streaming data that you're collecting. Yep. Other than that, you can upload your, all the health related data. Now, there's a convergence of the data on that platform. Apple is a big fish. As Google has taken over a lot of search engines, Amazon has taken over all the retail industry, right? What you guys think as a startup, you are working in silos. Silos mean you're working on with maybe certain hospitals on certain kind of data and certain kind of, the health records. Now you've been taken over by these giants who already have presence, platform, and everything, and they would just take over all that stuff, and you would become obsolete in terms of because you don't have that vast amount of data. So what risks you think in terms of these startups who are working in AI, machine learning, and all that stuff, but have access to limited amount of data?
But that have access to a limited amount of data. I guess the crux of your question is really, why do tiny tech startups exist when there are big companies?
Especially in healthcare industry. I mean,
because healthcare is so fucking broken. Like, really. And the proof of that, it's a great question. It's a thoughtful question. And the proof of that is that Google's tried so many times to release a new health platform, to start their own data collection initiatives, to build predictive models that are genomic driven. And I would bet money that they'll succeed quite a bit in a few different areas, but I would also bet that their most successful endeavor in healthcare is going to be the venture capital that they deploy into other healthcare companies. The specific answer to your question in the context of Epharmix, because it is genuinely a really good, thoughtful question, is that we very intentionally focus on being excellent at engaging difficult patients of low socioeconomic status working with multiple chronic conditions in order to collect rare data from those patients, where rare data are generally qualitative and don't exist anywhere else in the world. And at least for the time being, most of those patients aren't spewing out megs a day onto wearables and other platforms. In fact, they're pretty isolated. They're probably more than 50 miles from here. Yeah, and it's a different set of challenges, and it's a battle, frankly, that at least so far I think is very much worth fighting and doable by a small company.
And I'll say two things about my specific company and my specific industry. So what are the three main ways that social medical service providers collect information about their services? Word of mouth recommendations, online search engines, and print to paper directories. All of those are ostensibly free. And there's a really profound principal agent problem, and that the time required to collect that information is often not very carefully captured. So there's not a lot of money to be made by a Google to solve this problem, even though they very much could. And if they do, that's great. I'm a nonprofit, and if somebody comes along and solves my problem, then I can move on to the next thing in my life. So I would love for somebody to solve this problem. That'd be a good, wonderful problem to have.
So a couple things about, I don't know if you guys probably know this already, but about a year ago, there was a company that had, it was a startup, and what they were doing was collecting people's health data with their permission, instead of going through, so the patient owned their own data, which is what we want. And then by doing that, they got paid, instead of the big companies, they got paid to offer, they didn't have to offer their name and those kind of, just age, everything else. But by getting paid for that, which is a win-win, that those drug companies, insurance companies, they created like a, they could actually ask, do you take your medicine? Like the data that's just in these big, they don't have that kind of information. They don't have to, they don't know who is, I can't remember the word when you take your medicine, but yes, okay. So, which I think that's kind of very similar to what you guys are talking about. It's like giving the patient the information, and then if we get the communication out there to the patients, they're slowly this year, there's still many people that have no idea what is being done with their data. But as it comes out, they're going to be more careful about those things as long as we as technologists and the ones that are educated on to get it out to them to realize who you should give your data to and who you shouldn't. I would not want Google, I would not want Google fixing my medical problem because of the unethical stuff that they do. I would never trust that they had my best interest.
No, I'm going to call it. What unethical stuff do they do? What's an
So,
example? Sorry to put you on the spot.
No, because they use data to make money. So, okay, so for an example.
Everybody uses data to make money.
No, but not like that, okay, so the reason that I think it's different is because, like the schools, so they created this thing for our kids' schools. Well, to me, that would be a great thing to do. You have all this money, you have this huge corporation, make a difference in the world. And that's what I thought before I was educated, before I got into this industry or whatever. And to find out that they require their names, there's all this weird stuff that they're doing, and it's not right. It's so wrong that you have to read, like, there's a lot. I'm not that educated. I just know what I've read, but I can't remember it all.
And we're all welcome to our opinions, absolutely.
And
Blake inspired me to make sure we keep the conversation focused on AI. So
Sorry,
we're talking about
sorry.
Google AI, right? Talk about bias and misinformation in data sets and the impact that has and how we prevent it.
So I can give an example from Johego. So every time somebody searches in our app for a social medical service, we confidentially and anonymously record the time, location, and nature of that search. So then you can see in real time what's being asked for where. You can do predictive analytics on what's going to be asked for in what neighborhoods. Is there a sort of gap between the demand for services and the supply for services? Great. Sounds like we make the system more efficient. Well, the folks that are using our app are able to use our app because they have a smartphone. And so if we're getting a lot of hits from a particular neighborhood, is that a consequence of genuine disproportionate demand, or the fact that we happen to train more folks on using our app there, and or that the people in that neighborhood are able to afford smartphone applications? So I think a recurring theme we've been hearing is that AI machine learning should be used to augment decisions, not replace them, and this was, I think, a pretty good example of that, because of concerns about biases.
Just kind of following on that, have you thought about partnering with a technology company to perhaps put technology like in a pharmacy or something, so that you can have people when they go to pick up medicine or their groceries, ask them questions that feed your model so that you can better inform it and underserved population?
Yeah, we've also...
Repeat the question.
Pardon?
Repeat the question.
Okay, yeah, so the question was, have we thought about basically working with on-the-ground partners to have sort of access points for our information? And the answer is yes, and we would love to do it more. So if you have any leads in that regard, anybody in the room, please talk to me afterwards. But for example, like McDonald's is now the new town center. People go there to socialize. They go there to like get information through their Wi-Fi. They check their prescription and everything, right? And so setting up a kiosk in a McDonald's, or in a lot of librarians now are basically de facto social workers too. So the more people that we can engage and the more institutions we can engage in being these access points, the fewer people that are going to slip through the cracks and the better data we're going to have. So.
5 minutes. Cool, Chris.
Yeah. So my favorite last question for all three of you. So close your eyes, you get a magic wand. Within the context of your space, 10, 15 years from now, what does it look like when AI is applied? What's the dream? What's the possibility?
I'm going to go last.
Okay. Magic wand. Go.
I'm going to go second to last. Okay. So my sort of domain is very, very narrow. It's about the collection and verification and sharing of information about social medical services. So my big dreams are ostensibly small because they're really focused on that thing. So when Google debuted their Google Duplex program, I think it was last year. Basically, it's a piece of software that can speak to a human, and the human a lot of the time doesn't know that they're speaking to a software program. And the two use cases that they optimized for initially were setting up hair appointments and making restaurant reservations. There are probably bigger problems in the world than those two things, right? And it's right and good, maybe, while the technology is coming out of the gate to start with something that's relatively low risk. Like, oh, I'm sorry, I thought you said, you know, it was Saturday, but you actually said Sunday. Like, okay, who cares? No one dies, right? So, okay, that's all well and good. But in 10 or 15 years, if full duplex AI hasn't been engaged in the business of collecting baseline information about what's being asked where, so that WashU physicians or coaches who are in a position to help a suicidal child, or pastors or teachers or nurses, if they don't have access to the information, then I think it's a colossal societal failure. And I think AI is the solution to that.
That's a big question.
You're welcome.
So I think in the context of what artificial intelligence can realistically empower and enable, I think it really boils down to the steady shift toward more and more preventative care, particularly for the things that cause, the diseases that cause morbidity in humans, especially in the US, but everywhere, that are chronic and can be kept relatively inexpensive if certain things are done. I think that's a realistic 10-year approach. And I think that the power of AI there is actually twofold. One is to make that clinically possible, but the other, just as big challenge in US healthcare, is making sure that something that's clinically possible, such as predicting a downturn in a patient's condition, whether it's behavioral or cardiovascular or anywhere in between, it's also demonstrating that it's financially desirable and sustainable. So if I tell you that you give me $50 today and I'll prevent something from costing $500 2 years in the future, if I can persuade you of that beyond a shadow of a doubt and do it, then I think we're in a really good spot. I think that's the direction. Clinically and financially defensible preventative medicine is my phrase.
Cool. Dr. O'Leary?
I should have let Blake go last because he's brilliant, and that was a great summation of what we're trying to do. My lane is even more narrow than Michael's, so I'm interested in health communication. I think all of these applications are really important tools toward better health and longer lives and better living for the whole time that people are alive. I think people ought to feel good about their health care. They ought to feel like they can make really informed health choices for their own situation based on the best information that's out there. And that ought to be the same for people no matter what your insurance is, or the fact that you're living in St. Louis versus Kennett, Missouri, and you don't have any money or you do, you don't have any education or you don't. Whatever those things are, those things shouldn't matter, and right now they matter a lot. I think AI offers the possibility to sort of eliminate some of those huge disparities that people experience. And for our part, the communication piece is really important. So if you create all these systems and you don't figure out how to communicate with people to get good data from the start, and then to push back out good data so they understand, it's all just a really fancy waste of money and time. Right? It doesn't matter if it doesn't help people. So I'm interested in figuring out how to plug in with all of you smart people who do tech things and make sure the communication coming in is useful and the information going back out actually gets to people in a way that they can use it to make health decisions. If we're doing that, I think it's a win.
Amen. All right. Big round of applause for our panelists. All right.